Welcome, everybody. It's a very great pleasure to have the opportunity to introduce Dr. Gardenas today with us. So Dr. Gardenas is a senior lecturer in pharmacy at the University of Technology in Sydney, in Australia. Her teaching and research interests encompass different aspects of pharmacy practice, such as medication adherence, the evaluation of and implementation of professional pharmacy services and practice change in community pharmacy. Victoria is currently involved in 5 national and international research projects for the evaluation and implementation of professional services in community pharmacy. So Victoria is also the chair of the Pharmacy Practice Research SIG group at the International Pharmaceutical Federation, FIP, and she's an associate editor for research in social and administrative pharmacy and an active member of the Pharmaceutical Care Research Group at the University of Granada in Spain, where she comes from. Today, she's going to speak about her practice or research in implementation science. And the title of her lecture is Using Artificial Intelligence to Facilitate the Implementation of Services in Community Pharmacy. Thank you very much, Victoria, for being with us tonight. The floor is yours.
Thank you, Mary, for the kind introduction, and thank you for the invitation from the IMPACT Implementation Science Network, especially to Professor Mary Snyder and Professor Sabina de Guest. So it is my pleasure to be here today, and I'm going to share my presentation. Okay, I hope you can see it properly.
Yes.
Okay, excellent. So as Professor Snyder said, I'm going to present this webinar, which is focused on using artificial intelligence to facilitate the implementation of services, particularly in community pharmacy. So I'll be focusing in this setting. However, I guess and I hope the methods and the outcomes of this project are applicable to other settings in health and also outside of health. So the webinar overview is going to be focused on the paper that you can see on the slide. This paper was published in the journal Implementation Science the end of 2021. And I will be covering some of the background, where explaining the setting where the project was undertaken, the study objectives, the methods that we use, the results and outcomes that we got, some of the limitations and the conclusion of the project. And we will also have some questioning time at the end of the presentation. So I guess all the doubts or questions that you have during the presentation can be written down, and then at the end of the presentation we can have a nice discussion. I would like to acknowledge that I'm just the face of the project. However, this was an effort from a big research team. So it involved academics from the Graduate School of Health at the University of Technology, Sydney. So mostly I was one of the primary investigators, but also Professor Charlie Van Riemock, who was co-primary investigator, and also Dr. Lydia Musa. We also had academics from the School of Engineering who mostly helped with the analysis, as it was quite innovative for us. And this team was led by Professor Casca Musil. We had a professional association, so the Pharmaceutical Society of Australia, which is one of the major associations for pharmacists there. And we also had practitioner pharmacists who I will explain their role. but basically they were the ones doing all the implementation efforts. And then we also had practice chain facilitators who were the ones facilitating the implementation of different pharmacy services. So just to give you a bit of a background of community pharmacy in Australia, so there are about 5,700 community pharmacies in Australia for 45 million inhabitants, and community pharmacy is a very regulated market. So it means that there are location and ownership rules. So only pharmacists can own a pharmacy, and you cannot open a pharmacy wherever you want. So there are location rules regulating where, in which areas you can open a pharmacy. The market is regulated. As I said, it's very regulated, and the business is mostly driven by community pharmacy agreements. So these agreements are signed by the Pharmacy Guild of Australia and the Australian government every 5 years. And in those agreements, amongst other things, there is an allocation of the funding that it's going to be allocated to community pharmacy. So not only for dispensing, but also for the provision of professional pharmacy services. So a few years ago, I think around 10 years ago, there was a change in the way the pharmacy profession, the community pharmacy profession, was funded. So before, the funding was based on the product revenue, so on the margin of medicines. But that changed, and now there is a fixed fee for every product medicine that is being dispensed. And there are services which are funded by different stakeholders, which has made community pharmacy to go through a market differentiation. So it means some pharmacies are implementing new business models. So some pharmacies just focus on products and OTC, prescription medicines, but also other kinds of products, as you can see here on the right side of the slide. And then there are some pharmacies which are implementing a completely different model, which is focused on healthcare, on service provision. So those pharmacies are implementing different professional pharmacy services to get funding, to offer and differentiate themselves from other types of pharmacies. So today, in Australia, there are different pharmacy services that are being funded. And as I said before, there are different stakeholders funding those services. So on one side, we have the community pharmacy agreements services, which are funded by the government. So all these services, which I always call innovations, are services which are included in those agreements signed between the pharmacy profession and the government, and they get funding to be provided. So for example, in the last community pharmacy agreement that was signed, we had those administration aids which help or support medication adherence, state supply med checks or diabetes med checks, which is like a medication use review, home medicines review. Then in those community pharmacy agreements signed between the profession and the government, there is funding allocated for the investigation of new services that could be included in the following community pharmacy agreement. So for example, in the last agreement, there was funding to investigate a pharma asthma and rhinitis service, chronic pain med checks, indigenous medication review service, naloxone program, etc. Then there are other services which are funded by the industry, mostly the pharmaceutical industry. So for example, the med screen compliance, neurotherapy, or quality use of medicines. And then there are some services which are funded by the patient. So for example, glucose monitoring, vaccinations, smoking cessation, etc. And all these services have, or most of these services follow the same process. So at the beginning, there is a needs assessment in which there is an identification, mostly by academics, but also by the profession, by the pharmacy profession, in which unmet population needs are identified. Then based on those unmet population needs, there is a development of a new service, of an innovation that addresses those unmet population needs. Then once the service is designed and developed, there is an evaluation of the service. So there is an evaluation to see if that service is positive in terms of clinical, economic, and humanistic impact. And then if that assessment, that evaluation is satisfactory, there is an implementation of the service. However, I have to say that even though there is funding to implement those services, most pharmacies don't get any support to implement them. So it is assumed that just by the allocation of funding for the provision of services, pharmacies will implement those services. And we know that implementation is a very complex process, and there has to be active implementation strategies and an implementation program to make it work. So that's how the Health Destination Pharmacy program appeared. So this program was led by the Pharmaceutical Society of Australia in collaboration with the University of Technology, Sydney. And the objective was to reposition the pharmacist as a healthcare provider and the pharmacy as a health destination. So the objective basically of this program was to support and provide an implementation plan for pharmacies who were willing to implement new services to differentiate themselves in that very regulated market that I was talking about before, and to support not only training to implement new services, but also change facilitation, different tools to monitor how the business is progressing through the implementation of new services, consumer resources, etc. So it was basically an evidence-based program to support pharmacies change and implement innovations, pharmacy services. So taking this into account, the study objectives of this project were to explore the implementation barriers identified by change facilitators during a 2-year implementation program. So the Health Destination Pharmacy program I just mentioned in the previous slide. And our second objective was to predict the effectiveness of facilitation strategies to overcome implementation barriers using data-driven machine learning. Taking these objectives into consideration, these are the methods that we applied. So this study design was a mixed methods implementation study. So it had a qualitative component in which barriers for the implementation of professional pharmacy services were explored using a participant observation approach. And then it also had a quantitative component by which those barriers and also the implementation strategies that were applied to support pharmacies were analyzed. And that was the quantitative component. Studying community pharmacies in Australia, and this study lasted for 2 years. Regarding the implementation framework that we use, you know that it is very important to choose an appropriate implementation framework when designing your project, your research project. And this is taken from a paper from a narrative review. There are different types of frameworks, models, and theories. So we use 2 approaches. So we decided to use a process model and also a determinant framework. Basically, a process model is the one that guides or describes the implementation process, and then the determinant frameworks aids in understanding or explaining what influences the implementation, in this case, of the service. We decided to use the framework for the implementation of services in pharmacy, the FISH framework. And this is really a combination of the two approaches that I just mentioned before. So this framework hypothesizes that when a pharmacy aims to implement an innovation, like a pharmacy service, it can go through different stages. So the first one would be exploration, in which the pharmacy owners and the pharmacy staff consider the implementation of the service and consider the risk and the benefits of implementing that service. If that exploration is satisfactory, so it means that in that evaluation, the benefits outweigh the risk, the pharmacy can go through to the preparation phase, in which it gets ready to implement the service. So there is an adaptation of resources, an adaptation of the pharmacy staff. Basically, the pharmacy gets ready. Then if the preparation is satisfactory, the pharmacy can go to the testing phase, in which the service is tested in a limited number of patients. So it means that imagine you're trying to implement a medication review service. So, and your target population is 100 patients a month. So you would start testing how the implementation is going in 5-10 patients to see if there are any additional changes that should be done. And then finally, the operation phase is reached once the service is provided to the target number of patients. So in the example before, that would be reached when the medication review service is provided to the 100 patients. And then finally, we have another element which is very important. I think there has been a webinar on sustainability as well. So that would be achieved in this case when the service is integrated and routinized into the daily practice of the pharmacy. And that evaluation through that evolution, through the different phases is driven by different implementation factors or determinants. There are different names in the literature to refer to these moderators, which can be related to the service itself. So for example, is it too complex or not? To the individuals involved in the implementation process. So do they have the confidence to do it? Do they believe in implementing the services or not? The pharmacy itself, so does it have the resources, the layout, the local setting, the characteristics of the population attending the pharmacy, and the system. So are there any regulations in place, funding, policies, etc.? So basically, this framework that we use can be or is really a combination of different frameworks that have been published in the implementation science literature, such as the EPIS framework, the Exploration, Preparation, Implementation Sustainment, and the consolidated framework for implementation research, as you can see on the slide. The main strategy, the main implementation strategy that we used in this program was practice chain facilitation. So in practice chain facilitation, or the approach that we used was that there would be individual on-site facilitation visits to the pharmacy every 3 months. So every community pharmacy involved in the health destination pharmacy program received the on-site visit from a practice chain facilitator who had been previously trained to support pharmacists implement new services. During that visit by the by the practice chain facilitator, there was an identification of implementation barriers preventing the pharmacist and the pharmacy team to implement and increase the number of services that they were providing. As part of the facilitation process, also there was a provision of tailored change facilitation strategies to overcome the barriers identified in step number 2. And then finally, this was completed with continuous telephone follow-up and monitoring by the practice change facilitators. Data collection, that all the data was collected by practice change facilitators. This means the people that were visiting the pharmacies to support and assist pharmacies enrolled in the project to implement new services. So we had data collection form, as you can see on the slide. This is just a couple of screenshots, but this was much longer. So data was collected every 3 months. This means that data was collected every time the practice change facilitator went to the pharmacy. And this is really the guide that was used through the participant observation process to collect qualitative data. Then the data was collected and then transferred into a database. What data was transferred into that database? So all the identified implementation factors that acted as barriers. So whenever the practice change facilitator went into the pharmacy and identified that there was a barrier to implement new services, that barrier was recorded. Then the associated facilitation strategies that practice change facilitators used to overcome each of the identified barriers. Then they also had to record when each barrier was identified and also the time period and the facilitation strategy and when the facilitation strategy was conducted. And finally, they had to register whether the barrier was resolved or unresolved. So this information could be recorded during the 2-year program. So probably in most cases, practice change facilitators identified a barrier, for example, at baseline, and then it wasn't resolved until 3 months later because it took a lot of time to implement implementation strategies and also to resolve the barriers. All the data, then all the qualitative data was coded by a one of the research managers. So the first data that was coded was the implementation barriers. So all the information regarding implementation barriers that were collected by practice change facilitators was then coded by the research manager according to 3 frameworks. To the consolidated framework for implementation research, therefore based on the theoretical domain frameworks, and also based on the integrated checklist of determinants of practice. So basically, all the qualitative data then was coded and entered into the database based on these 3 frameworks. The second data and information that was coded was the facilitation strategies used and applied by practice change facilitators to overcome each of the identified barriers. So this coding was based on the findings from 2 systematic reviews. And they were also labeled with an outcome. So strategy was effective or not effective. So this classification, as I said, was based on 2 reviews. The first one by Doherty, it was taxonomy for facilitation strategy. And the second one from one of the researchers involved in this project, which was based on facilitation strategies used in randomized controlled trials in healthcare settings. As you can see, there are 3 categories in this classification system. So we have a primary category, secondary, and tertiary. So the more or the higher level of detail, the higher the level of the category. So for example, facilitation strategy group. awareness of need to change. So increase the awareness of the pharmacy staff involved in the implementation process of the need to change and to implement new services. Then we have secondary categories and then tertiary categories. How can you achieve that? So you can provide audit feedback through a written report, audit feedback through a visual presentation, and you can also do that through a verbal presentation. Same one. So these are the different categories that we had for the facilitation strategies, and as you can see on the slide. So I'm not going to go into the details of each of those, but you will have the presentation after the webinar, so you can check all the details afterwards. So it's all in the presentation. One important element that we used here is how we analyze the data. So we decided to use a machine learning approach, which is really part or a subtype of artificial intelligence. How does this differ to traditional approaches of how we usually analyze data in pharmacy practice research and also in healthcare settings? So as you can see in the traditional approaches, we have a data set, and then we have some rules that we want to apply when we analyze the data. So based on that, we analyze the data and we get an output. And that's what we usually report in our research papers, our research reports. But in the machine learning approach, we have slightly different way of analyzing data. And I have to say, I'm not an expert in artificial intelligence or machine learning. So that's why we were collaborating with the School of Engineering of the University of Technology, Sydney, who were really helpful in analyzing the data. So in the machine learning approach, what we usually do is we have a data set. So it comes from the fieldwork in which we collect the different data relevant to the project, and we also have an expected outcome. So through machine learning approaches, we have a trained model, and in that trained model, we can add or test it with new data and get a new output. So it is a slightly different approach. So we have really a training set in which we train the machine learning model, and then a test set in which with new data, we can keep on getting new outputs on that trained model. And there are two different approaches that we can use, supervised or unsupervised, which really differ in the way the data set is structured and what outcome we want to get out of the data set. So in this case, we use the supervised approach because we already had a data set with different categories, label, numerical data. So it was a structured data set, and we wanted to predict a numerical data. So how effective to predict how effective a given strategy would be to overcome an implementation barrier. We use machine learning with random forest, and we decided to use this method due to its explainability and accuracy. So the outcome that we got was a predictive resolution percentage. And that PRP was given to each of the facilitation strategies. So basically what we got out of this project is, if we have a given barrier, how can we, or what's the facilitation strategy most likely to overcome and to be effective to overcome that given barrier. So at least in our setting in community pharmacy, how practice team facilitators approach the implementation and the provision of facilitation strategies is by a test and trial way of doing things. So, okay, let's try if this works. If it doesn't work, let's try with a different strategy. So we really wanted to get a prediction. So if we have this barrier, how can we overcome it? So what's the prediction or the chances that we can get a facilitation strategy work? We developed an algorithm. So it was used to rank the facilitation strategies in order of their predictive resolution percentage. So it means that the higher the predictive resolution percentage, the more likely that the strategy was predictive to overcome a given barrier. And then we use, to validate the analysis, we use a 10-fold cross-validation technique. So based on these methods, these are the results that we got. So we had 19 pharmacies. Oops, sorry. We had 19 pharmacies participating in the change program, and they were all located across different regions in Australia. So the size of the pharmacies was very diverse. On average, they dispense almost 94,000 prescriptions per year, but this range from 24,000 to 223,000 prescriptions. Employees range from a minimum of 2 to a maximum of 46. And then the program involved the participation of 6 practice chain facilitators who assisted with the implementation of the program. During the 2-year program, we identified 1,130 barriers and associated facilitation strategies. And the random forest algorithm that we create was able to provide close to 97% accuracy in predicting the most effective strategies to overcome the barriers that were identified. What I'm going to present now are the results. So different strategies used to address the top 20% of the most common implementation barriers. As you can guess, we identified a lot, very, very high number of implementation barriers. However, most barriers repeated across all pharmacies. So the frequency of identification of some of the barriers was just one pharmacy, one time. So we decided to focus on the top 20%. So this, as you can see on the slide, the most common barriers were the inability to plan for change, and this was identified 184 times in 16 out of the 19 participating pharmacies. Then we also had lack of internal support to change, and that was identified 128 times in almost all pharmacies, so 18 pharmacies. We also identified lack of knowledge and experience, and that was identified 84 times in almost all pharmacies as well. Lack of monitoring and feedback in 61 times in 14 pharmacies. Lack of individual alignment with the change, and that was identified 49 times in 14 out of the 19 pharmacies. Undefined change objectives and lack of objective feedback, and that was identified 46 times in 16 out of the 19 pharmacies. And finally, lack of time or lack of resources, and that was identified 43 times in 15 out of the 19 pharmacies. So as I mentioned in one of the method slides, we had different frameworks for the coding of the implementation barriers, including the theoretical domain frameworks or the consolidated framework for implementation research. So you can see here on the slide the different definition for each barrier and where the definition is coming from. And we have that for all. So what I'm going to present in this table is the predictive resolution percentage of strategies that were used to resolve the most common barriers identified in this research. So as we could see on the previous slide, an inability to plan for change was the barrier most frequently identified in this research. So in the different strategies applied with the highest predictive resolution percentage were engaged stakeholders by creating ownership of the change with a PRP of 84%, equip stakeholders with training with a PRP of 83%, and adapt area of focus to meet changes needs with a PRP of 81%. So the second most frequently identified barrier was a lack of internal support for the change, and these strategies more likely, or with the higher PRP, more likely to be effective, were engaged stakeholders by creating ownership of the change with a 78%, empower stakeholders to develop objectives and solve problems with 73%, create buy-in of the change among stakeholders with 58% PRP. Third one, a lack of knowledge and experience related to the change. So the most the strategy with the highest PRP was create a collaborative environment conducive of change with a 99 PRP, equip stakeholders with training with a 93 PRP. The next one, a lack of monitoring and feedback of the change. The most effective or predictive effective strategies was feedback and implementation progress with a 99, and ensure continuous monitoring of implementation measures with a 68 PRP. Next barrier, most frequently identified, lack of individual alignment with the change, and in this case, the most with the strategy with the highest PRP was to encourage participation and facilitate discussion among stakeholders, empower stakeholders to develop objectives and solve problems, and create buy-in of the change among stakeholders. The following barrier most frequently identified was undefined change and objectives and lack of objective feedback. And you can see the different strategies here on the slide with the allocated PRP and a lack of time finally with 2 potential strategies that could be applied to resolve it with their associated PRP. This is also, you can check, I'm not going to go through these tables, but this is also a different way of presenting the results. So it means that, or the way in which these results are presented can be used by practice chain facilitators in pharmacy settings or in other settings if these outcomes want to be applied, by identifying different facilitation strategies that I mentioned in the method section, how they can be applied, meaning all the details according to those primary, secondary, and tertiary categories, and how they can target different barriers faced to implement the professional pharmacy services with their associated PRP. Some limitations, I would like to acknowledge some limitations as always from this research. We have the first one, or the main limitation of this research is that usually machine learning and artificial intelligence rely on largest amount of data. So it means that usually it implies that the larger amount of data that you have to train the model that you are creating, the highest accuracy that or predictive accuracy you can get. However, I have to say that our accuracy was close to 97%, which is quite good. But in the future, it would be desirable to get higher volumes of data. We also had not so high number of pharmacies participating in this research, so 19 pharmacies, which can limit the representativeness across community pharmacy in Australia. We also had some qualitative data, which had to be coded by one of the research managers, and there could be variability in how this research data could be coded. However, in order to minimize this potential bias, we used the same person to code the data, and this was also validated by 2 other researchers. And then in some cases, there was a combination of different strategies. So not one single strategy was used to overcome a barrier. So in some cases, there was a combination of more than one strategy to overcome a given barrier. So to conclude, because we are close to the end of the session before the questioning time. So the outcomes of this research highlighted the different implementation barriers that were most common to implement new pharmacy services in community pharmacies in Australia. So for example, the most common barriers, as you could see in the results section, was inability to plan for change, lack of internal support of the change, and lack of knowledge and experience regarding the change. We also had, as an outcome, the predicted effective strategies. So if we face those barriers again, how could we overcome them, and what is the likelihood or the prediction that those strategies would be effective to overcome those given barriers. So empower pharmacy teams to develop objectives and solve problems, engage teams by creating ownership of the change, and equip teams with training. So these study outcomes shape how change facilitators, so those people that go into, in this case, pharmacies, but into other settings, and support the implementation of innovations in different settings, can more effectively implement tailored facilitation strategies, and they can shape future implementation projects for more efficient implementation of innovations like professional pharmacy services in community pharmacies. So thank you very much for your attention, and I'm open and more than happy to answer any questions that you may have. Thank you very much.
Thank you, Dr. Garcia Cardenas, for this presentation that really kind of highlighted how you can use artificial intelligence in order to enrich your implementation science projects. And I would like to invite everybody who has a question, who has a suggestion, a reflection, to put it in the chat, and then we can give you the word in order to address your comment or your question. I would like to start with asking you, this is really getting insight in your implementation processes while you are, let's say, while you are building your implementation science project. I wanted to ask you how you would see the approach of starting before you do this implementation science project with trying to get a grasp on the context. In most of our studies, or all of our studies, we start with a thorough contextual analysis, which gives us then the basis for a subsequent phase to fine-tune our intervention and our implementation strategies. So it's paradigmatic, a different approach you are taking. And I just wanted to have your reflection upon if this idea of really looking very carefully into in a context and trying to identify your barriers, how you see this? Is this to some extent valuable, or how do you see your methodology being combined? So it's truly trying to see the phases of an implementation science project, and if your approach kind of calls for shifting gears, or if there's perhaps an option for integration.
Thank you, Professor De Guess. It's a very relevant question. I can answer from our experience in different implementation projects. So for us, one of the key elements has been to, obviously before even designing the project, choosing your implementation framework, your implementation theory, your implementation model very, very carefully. And there are different tools in the literature. Particularly, there are two tools that can support researchers according to their research question to select the most appropriate framework, theory, or model. So according to based on our experience in pharmacy, we have been using the framework that I presented in one of the slides, the FISH framework, which is really an adaptation of previously published frameworks in the implementation science literature. So for us, having that process that guides the implementation through the exploration, which is really before doing anything, planning, exploration, preparation, testing. So before the implementers start with the hands-on implementing the change, the innovation, the service, is critical. And also considering all those factors that moderate how the pharmacists go through the different implementation stages. What really moderates, what affects, what's hindering, what's facilitating, moving and progressing through the implementation process is critical. So I guess my recommendation is to spend as much more time as possible in that planning, in that preparation, in selecting your frameworks really carefully, in evaluating the context, in evaluating the implementers, in evaluating the innovation, the service before you start with the fieldwork. Because I think, according to our experience, that saves a lot of time later on, and it allows you to have a more effective implementation plan.
Thank you so much. I would like to give the word to Michael Simon. Perhaps you can introduce yourself and ask your question. Juliana, could you unmute Michael?
Hi, can you hear me?
Yes.
Yes.
Okay. Thank you very much for your very interesting presentation. If I would have known that I don't need to write it down, that would have been more quickly. My question was a little bit how I understand it, and I'm very much interested in the machine learning part. And so basically, I mean, it was 19 pharmacies. And there's, for instance, many of the strategies were referring to stakeholders and so forth. And I would suspect that is actually a pharmacy level type of strategy. So that basically a pharmacy decides to do this, and then this strategy is in place. Therefore, how was actually the clustering taken into account, because and also the time varying nature of this, right? I mean, the 2 years period, I would suspect that they start probably not having that strategy in place, and then at some point they flip. How was that handled from the machine learning algorithm?
That's really relevant, Michael, a really relevant question. We did not take that into account. We are taking that into account now in current projects, which haven't finished, but it's something that definitely should be considered, because what we know is that the barriers faced and also the strategies to address those barriers are definitely not the same in an exploration phase. So even before the implementation has started, or really the hands-on, the implementation has started, compared to a testing or an operation phase. So definitely my recommendation, if you are considering doing this analysis and this approach in future projects, taking into account the time difference and the clustering. So definitely we didn't do it because we did not consider it at that time, but it's something that it would enrich the outcomes and also the applicability of the results of this research.
Okay, thank you very much.
Thank you, Michael.
Thank you, Michael. Marie, may I give the word to you?
Yes, thank you very much for the very inspiring presentation. It's probably also linked to the question of Michael before. I was wondering, you said you didn't take into consideration the combination of strategies to overcome barriers. That was also part of my question. Maybe there are a time dependency between the different strategies that that pharmacists are using. So I was wondering if you had any ideas, or if you were doing new research on the way of analyzing this combination of strategies. Maybe they inform about the way of tackling barriers in the settings.
We thank you, Marie. Again, very relevant question. We did try to analyze the different combinations. However, we could not do it due to the high number of potential combinations. So there were, I don't remember on the top of my head, but there were hundreds of potential combinations of strategies. So because of that high number of combinations of strategies, we had very low numbers of those combinations. So imagine if you combine strategy A, B, and C, and you try to analyze it, you would have to, in order to get enough data, you would need a repetition of strategy A, B, and C. You would need a high number of that combination, and we didn't, because we only had 19 pharmacies. So in the future, in order to be able to analyze that combination of strategies and the predictive resolution percentage, we would need a higher volume of data, which we didn't have in this project, but it's definitely something that we will consider doing in the future.
Thank you very much.
So we have a question of Francesca Zuniga. Francesca, may I give you the word to introduce yourself and ask your question?
Yes, hi, Victoria. Many thanks for this excellent presentation. I was getting a lot of ideas for my own work, so that was very nice. I was thinking about the trained facilitators that then went and did the data collection. So you showed these data sheets, and I think it's really excellent to have these 3 monthly looking into the system, what's going on, what's happening. And I was wondering, who were these facilitators? So did they know pharmacies, or were they just implementation practitioners who know how to facilitate? And what role do you give to this experience of knowing the field? How could they question then actually, and going deeper and support with this facilitation? That would be one question, but maybe first, and then I have another one.
Okay, maybe I will answer this. So we had a job description for these change facilitators. So they had to meet, it was quite exhaustive. So they had to meet certain requirements. And one of them was that they had to be pharmacists, because yes, one of the requirements. And that was chosen because the implementation effort, or really implementing those services, when implementing those services, pharmacists have a lot of questions regarding clinical elements, communication with GPs, communication with patients, networking with other pharmacists, available of clinical resources. So from previous research, we thought that a lot of questions were a lot of barriers were very pharmacy specific. So that was one reason, or we decided, or the research team decided, that they had to be pharmacists. But amongst that, there were other requirements. So my recommendation, if you have to employ practice change facilitators, that you elaborate a job description. So in order to employ the appropriate person. So we had other requirements, like they went through an interview process, obviously. So they had to meet communication requirements and other elements included in the job description. And before we started with the implementation programs, practice change facilitators went through a very intense training. So the research team, which included academics, pharmacy academics, staff from the professional association, also GPs, other pharmacists, so were involved in the training. So they did not only receive clinical training, but they also received a lot of implementation training, how to use all the resources. So the participant observation guideline, how to identify implementation barriers, how to develop implementation strategies, how to transfer that information into the database, where to find information. So it was very intense. We also had a training program, and that was also one of the requirements. They had to go through this training.
That would be an interesting publication to see. So how did you train them to actually be able to do this? Because that's a need in other projects, I assume, as well. So that's very interesting.
I have to say, that's a very good idea. We haven't documented it in the form of paper, of a research paper, but we have used practice change facilitators in previous projects. And we believe that that training is essential, especially in implementation, because and we have been in other projects, we have seen very interesting strategies requested by practice change facilitators. So for example, they want more training from the research team. They start creating WhatsApp groups to get support from others. So they start creating their own network, and they start creating networking events. And so that would definitely be very, very interesting. And I have to say, if you need further information, I think my email is on the presentation. So please do not hesitate to email me.
Yeah, many thanks. I will refrain from my next question. There are other questions.
I'm just kind of going, Claudia Huber, may I invite you to introduce your question and also give us information where you are calling in from? Claudia.
Yes, hello. Thank you very much for your excellent presentation, Victoria. I'm Claudia Huber, working at the University of Applied Science in Freiburg. And my question goes into the direction of data protection. What do you think about artificial intelligence and privacy or data protection? And do you know which regulation are already in place and to which extent they need to be considered?
Absolutely. There are more and more regulations regarding artificial intelligence, and there are ethical considerations, confidentiality consideration, and I have to say it's a field which is evolving really, really quickly. Mm-hmm. So I think because more and more people, more and more researchers, companies are using this approach, regulations are being implemented in place. I think it changes according to the country. I know in Europe they are regulated by the European Union. I don't know the specifics of that because this project was based in Australia, and when we conducted it, there were no potential issues regarding confidentiality and ethical issues, but absolutely there are. So my recommendation before starting any project which applies artificial intelligence is to check and align with the local regulations. For example, I know the European Union now, for every European Research Council grants that applies artificial intelligence techniques, every researcher has to align with the UN regulations and state how they are going to meet those regulations. So I don't know in the case of Switzerland or other countries, and I don't know the details because this, as I said, this was based in Australia, and by that time there were no issues in place, but absolutely, we need to make sure that we meet those ethical, confidentiality, data protection requirements.
Thank you.
Thank you, Claudia.
So I would say, Marie, you have another question. Why don't you ask it? We still have some time.
Yes, another question, Victoria, about the implementation strategies that you found out in your study in Australia. If you would replicate your study, for example, in Spain or somewhere else in the same kind of context, would you expect very different strategies, or would you expect similar strategies? What is your opinion on this?
Yes, very, very good question, Marie. So community pharmacy, for example, in Spain is quite different to community pharmacy in Australia. So in Australia, there are bigger pharmacies. They look more commercial compared to here. Here are still very quite small, and there is a local market. So I guess based on my experience, I would check, or I would compare the context. So I would compare the pharmacies that participated in the project. So for example, here it's impossible to find a pharmacy with 46 employees. So I would double check what are the characteristics of the pharmacies that participated, and then try to see if those strategies would fit within the Spanish context. Having said that, I have to say that we have done previous projects. We didn't use machine learning, but we did identify barriers for the implementation of different services, for example, in Spain, and the barriers faced were not that different compared to those identified in Australia. So even though the context is obviously different, the barriers faced by pharmacists are not that different. So it would require a level of adaptation, but not 100%. So yeah, that would be my recommendation, or according to my experience. No.
Thank you.
So I would like to add a question from my side. If you look 5 years ahead, your approach would be used by implantation scientists, what would that mean for the evidence base in view of implantation strategies?
So it means that if we have, so I don't know if I understood, Professor De Guest, your...
No, it's primarily a question of, we are absolutely in need of more evidence-based approaches to choose our implantation strategies, to also look at the effectiveness of implantation strategies. And so my question is, looking at your methodology, and we look 5 years ahead, if everybody would use that, what would be the result in view of this major gap which we now have in the literature?
Okay, so I guess there would be an optimization of resources, because at the moment, I think I mentioned that the approach currently used by practice chain facilitators and also by implementation researchers sometimes is based on trial and error. Let's try this. Let's see if it works, and if it doesn't work, let's try a different approach. So I guess this adds evidence on the strategies that you could use in the future to implement different innovations, different services in pharmacy. So if I face this barrier, instead of saying, okay, I think this strategy will work, or let's try this and see if it works, or somebody suggested this, yeah, let's try. So I guess I would go to the list of results, and instead of saying, okay, let's see if this tries, I would check, okay, so what are the chances? If I face this barrier, what are the chances this strategy will be effective? So I think it adds, answering your question, it adds evidence on how to optimize implementation resources, on how to optimize implementation in the future.
So that's a wonderful way in order to close our discussion. Truly wholehearted thanks you. The work that you have done is, as you have also felt in discussion, very inspirational for us. We really look forward to see how you further report on the project you're currently doing. My care start in Switzerland is an implantation science project with Marie Schneider as principal investigator. And so even non-pharmacy projects can really benefit from thinking through your approach to also integrate in their studies. So truly wholehearted thank you. Swiss Implantation Science Network is very grateful for you. And I would like to conclude this session. And Juliana, can you please add the last slides? Wonderful. So I would like to inform everybody, and we will do also an information campaign coming in the coming month. We will host in Basel the European Implantation Collaborative, who will have their meeting the 8th and the 9th of June. And so it would be wonderful to meet you in person here in Basel. Also, do not hesitate to submit abstracts. You can explore the website that is being put here forward. And for our impact network in Switzerland, In the coming months, we will also advertise the webinars for 2023. We are working on a vibrant program that is cutting edge in view of implementation science topics, and we very much hope to also welcome you then online, but of course then hopefully at the EIC event also in June, in person in Basel. We are mid of December. Here in Switzerland is very dark at this time of the day. Some places in Europe not so much, or in other parts of the world it's still very light or even darker. So that means that it is also the right moment in order to wish everybody a wonderful end of the year, a peaceful, and I repeat it, a peaceful holiday season, where we also are living the real life in our families with our loved ones, and we very much look forward to continue with you our impact journey in 2023. Again, many thanks to Dr. Garcia Cardenas, and many thanks to all of you for participating in this webinar.